Welcome back to Deep Dive Ortho, the show where we unpack complex topics in musculoskeletal medicine to give you those essential insights. Today we're delving into a fascinating, though quite rare, orthopedic injury. It poses some unique diagnostic and management challenges. We're going to explore Latissimus dorsi ruptures, a condition I think is particularly interesting for anyone involved in sports medicine or upper limb surgery. It's a real pleasure to have you here to guide us through the nuances of this condition.
It's great to be here, thank you. This condition, despite being uncommon, it really highlights the need for a precise understanding, especially when we're dealing with high-demand patients. So, yeah, it's a great opportunity to explore the current thinking and best practices.
Okay, brilliant. Let's unpack this then. For those of us who perhaps don't encounter this injury very often, could you maybe paint a picture of the latissimus dorsi muscle itself first? Where exactly does it sit, and what's its crucial role?
Certainly. Well, the latissimus dorsi is quite a substantial muscle, very broad. It originates primarily from the low thoracic spine, that's T7, all the way down to L5, and also from the iliac crest, the thoracolumbar ponerosus, and the inferior angle of the scapula. So a wide origin. But here's a really key anatomical point. Despite this large origin, all that power converges onto a single, quite small insertion point. That's the bicipital groove, right along the proximal shaft of the humerus.
Right.
And if you think about the dimensions, studies show the tendon can be about 3.1 centimeters wide, maybe 8.4 long, similar size to the pec major tendon, actually. But because of that focused insertion, that's almost invariably where acute ruptures happen, right there.
Okay. And functionally,
Yeah.
what's it doing day to day, and especially in athletes?
Functionally, it's a real powerhouse at the glenohumeral joint. It works with the teres major and pec major to adduct, bring the arm in, and medially rotate the humerus. It also plays a role in respiration, surprisingly to some. And, crucially for this discussion, it's massive for throwing and overhead athletic movements. And another critical detail, which we'll definitely come back to, is that the tendon itself twists. It externally rotates about 90 degrees just before it inserts onto the humerus.
Right, that rotation sounds important. So, given its role in these really high-demand dynamic movements, I'm curious about how these ruptures typically happen. What's the usual mechanism? And what are the classic signs a clinician should look for, perhaps especially those signs that might be easily missed?
Yeah, these are, as we said, rare, and they almost always stem from an eccentric overload. Think about the follow-through phase of a throwing motion, or perhaps a resisted contraction when the arm is forced into hyperabduction or external rotation. Water skiing is another classic one. So, overwhelmingly sports-related. We see them in elite baseball pitchers, water skiers, increasingly CrossFit athletes, sometimes tennis or golf. Clinically, patients typically present with pain, usually posterolateral shoulder and upper arm pain. On examination, you might feel local tenderness, maybe even see a noticeable deformity over the muscle belly itself, sort of bunching up. And there's often pain if you ask them to resist shoulder adduction and internal rotation. But here's the interesting and sometimes misleading point you touched on. Patients might still have a full, unrestricted range of motion, even with quite a significant tear.
That is really counterintuitive, isn't it? Because we often equate a significant tear with a loss of movement. Does that make diagnosis tricky initially?
Absolutely. It can definitely be a pitfall. You might examine the range of motion, think it's okay, and potentially miss it. However, the acute injury itself is often accompanied by some pretty strong clues. A sudden popping sensation is common. Sometimes the patient actually hears it, and usually significant bruising develops, ecchymosis. Plus, you might feel a palpable loss of the normal muscle contour or notice an asymmetry of that posterior axillary fold compared to the other side.
Okay, those sound like critical clues then, despite the potential for full movement.
Exactly. Got to look for those specifically.
Right. So, with that clinical picture starting to form, what diagnostic tools do we then rely on to actually confirm the rupture and, crucially, assess how bad it is?
Well, for diagnosis, plain radiographs, x-rays are often the first step, but they're primarily to rule out other things, like an associated bony avulsion. In isolated tendon tears, the x-rays are usually unremarkable, normal, essentially. The definitive diagnostic tool is magnetic resonance imaging, MRI. That's what really gives us the detail.
And what are we looking for specifically on the MRI?
So on MRI, we're typically looking for increased T2 signal. For those less familiar, that basically shows up as brighter areas, indicating fluid, inflammation, or damage within the tissue. An MRI is absolutely essential for differentiating, is it a complete tear? Is it partial? Is it just within the muscle belly, an intramuscular tear? But here's a critical diagnostic insight, a real pearl. Standard shoulder MRI protocols might not actually capture the entire musculotendinous unit of the latissimus dorsi. It extends quite far down.
Ah, I see.
So if your clinical suspicion is high, you really need to explicitly request an extended field of view. Ask the radiologist to include the lateral chest wall. Otherwise, you could miss the full extent of the injury.
That's a very practical tip. So the main driver for seeking diagnosis is usually the functional limitation then, the pain and weakness.
Yes, exactly. That's typically what brings the patient in the pain, the feeling of weakness, the inability to perform their sport or activities at the previous level.
Which brings us to the next big question. Once you have that confirmed diagnosis, how do you decide the path forward? Non-operative versus surgical intervention. What guides that decision? What are the indications for each approach?
That's the key management decision point. For, I'd say, the majority of patients, especially those with lower physical demands, or if it's a partial rupture, maybe a tear at the musculotendinous junction, or just a muscle belly strain, non-operative treatment is typically very successful.
Okay. And what does that involve?
It usually involves an initial period of rest, maybe a sling for comfort, pain control, obviously, then progressive shoulder range of motion exercises, and eventually strengthening. The goal is to allow return to activities once they have full, pain-free motion and good strength, and importantly, restore the balance around the shoulder girdle, the rotator cuff, and scapular muscles. And there are quite a few reports showing that patients, particularly with those partial tears who keep decent function, they do remarkably well conservatively, high rates of return to pre-injury activity levels.
Right. But what about the other group, the high-level athletes?
Exactly. So for the high-demand athletes, particularly young, active people aiming to get back to a high level of sport, or for those with complete avulsion injuries right off the bone or significant mid-substance tendon tears, well, surgical repair is generally advocated. Now, there aren't rigidly defined absolute indications for surgery set in stone, but open repair has certainly shown good effectiveness in relieving that posterior shoulder pain, restoring function, and increasing strength. And there's a good argument for early primary repair, ideally within a few weeks, to try and prevent the tendon retracting too far and getting scarred down, which makes later repair much harder.
Okay, that makes sense. So for those high-level athletes needing surgery, let's talk technique. What does the surgical repair actually involve, and what are the critical anatomical points the surgeon absolutely has to keep in mind during the procedure?
Right, so there are essentially two main open repair techniques described. The suture anchor technique, using anchors drilled into the bone, and the unicortical button technique. The latter is often preferred now.
And why is that? What's the advantage of the button?
Well, the unicortical button technique generally offers a very strong fixation. It uses a small metal button on the far cortex of the bone, spreading the load. It's low profile, too. For positioning, the patient is usually placed in the lateral decubitus position lying on their side. The affected arm is abducted and internally rotated, often using a dynamic limb positioner. This gives optimal access to that posterior axillary fold where the tendon should be.
Right.
The surgical approach itself can be either a single incision in the posterior axilla, which you can extend if the tendon has retracted quite a bit, or sometimes a dual incision technique is used. During the exposure, it's a mix of blunt and sharp dissection to carefully find the retracted latissimus tendon, and often you'll encounter a seroma cavity, basically a pocket of fluid near the stump. That's quite common.
Okay, so you found the tendon, dealt with any fluid. What are the core steps of the repair itself then?
From there, the key steps involve, first, thoroughly mobilizing that tendon. You need to free it up from any adhesions it's formed proximally to make sure it can actually reach its original attachment point, its footprint, without too much tension.
Makes sense.
Then, you pass strong sutures through the tendon end. Often we use something like #2 fiber tapes, which are flat, broad sutures passed in what's called a Krakow fashion. That's a locking stitch pattern designed to get a really good grip on the tendon substance. Next, you prepare the humeral footprint. That's the spot on the humerus where the tendon attaches, just anterior and inferior to the teres major insertion. You gently decorticate the surface, maybe use a curette to roughen the bone slightly to promote healing.
Right, creating a good bed for it.
Exactly. Then you drill 2 small unicortical holes just through the neocortex, about 1 to 2 centimeters apart. The future buttons, preloaded with the sutures from the tendon, are then passed through these holes using a special tension slide technique. They flip and engage on the far cortex, providing that strong fixation.
Okay, it sounds quite meticulous.
It is. And this brings us back to that anatomical point we mentioned earlier, that 90-degree external rotation of the tendon just before it inserts.
Yeah.
It's absolutely paramount that the surgeon orients the tendon correctly during the repair to replicate this natural anatomy. If you don't, You won't restore normal function.
That's a crucial detail. And what about the risks, the nearby structure?
Yes, the anatomy here is, well, it's crowded. Surgeons must be acutely aware of the vital neurovascular structures nearby. Things like the short head of the biceps tendon, the pec major tendon itself. More deeply, you have the radial nerve, the teres major muscles right there, the cephalic vein, and crucially, the axillary nerve. It lies deep and proximal to the latissimus tendon, sort of in the floor of your exposure. You have to be extremely careful not to damage it. Also, branches of the posterior brachial cutaneous nerve, which provides sensation, run through the area and need careful identification and protection if possible. Meticulous dissection and protection are critical.
Absolutely. It sounds like a procedure demanding real anatomical precision. Given those intricacies, what does the recovery look like post-operatively? What's the typical rehab protocol, and what sort of timelines are we looking at for getting back to activity, especially sport?
Yes, postoperative rehabilitation is absolutely crucial for a successful outcome. You can do a perfect repair, but if the rehab isn't right, the result won't be optimal. Immediately after surgery, the patient goes into a sling, usually to protect that repair. Passive range of motion exercises. So the therapist moving the arm gently typically start around 2 weeks post-op, but with caution. Usually abduction is limited, kept under 90 degrees for the first 6 weeks or so.
Okay, protecting the repair early on.
Exactly. Then strengthening exercises begin, usually around the 6 to 12 week mark, gradually progressing. For overhead throwing athletes specifically, a structured interval throwing program is usually initiated around 16 weeks, 4 months post-op, and return to full activity in sport.
Well, that's generally permitted at a minimum of 6 months. Often it's more like 6 to 8 months post-operatively before they're fully cleared for competition.
6 to 8 months. Okay. And the results? What does the evidence show for these operative repairs?
The results reported for operative repair, particularly using techniques like the unicortical button, generally show a near-complete or complete restoration of the patient's function and strength. Patient satisfaction tends to be high. The evidence base, as we'll discuss, is still somewhat limited, but the available studies do show excellent outcomes. High rates of return to the same level of competition for these operatively treated athletes, which is often the main goal. That's encouraging for those high-demand individuals. So it's clear that while these are rare injuries, they really do require thoughtful, individualized management. As we sort of wrap up this deep dive, what final insights or take-home messages can you offer on the current evidence base and the clinical judgment needed when dealing with latissimus dorsi ruptures?
Well, I think it's important to reiterate that the literature here is still relatively limited. It's mainly case reports and small case series. We don't have large randomized controlled trials comparing different treatments, for example. And that raises an interesting question for future practice. We know from biomechanical studies on other tendon repairs, like distal biceps, that suture button fixation often tests stronger than suture anchors. But we don't yet have direct comparative studies specifically for latissimus dorsi repair confirming this translates clinically. So that underscores the need for more research in this specific area.
A gap in the evidence.
Yes. But for clinicians managing these now, beyond the surgical specifics, some key pearls maybe. Ensure your humeral incision is adequate for proper footprint exposure. Don't underestimate how far you might need to see. Recognize that you might find that seroma cavity during dissection expected. And really focus on achieving maximal internal rotation of the humerus during the repair, as that optimally exposes the intratubercular groove for fixation. And the potential pitfalls, as we said, are largely anatomical. It's all about respecting the proximity of those nerves, the axillary, the radial, the posterior brachial cutaneous nerve. So ultimately, it's about combining the current understanding, limited as it may be, with really careful anatomical dissection, sound surgical technique, and tailoring the management non-op or operative to the individual patient's demands and their specific goals.
This is a fantastic summary. This has been an incredibly detailed and insightful deep dive into latissimus dorsi ruptures. You've really illuminated what is quite a nuanced area of orthopedic surgery. Thank you.
My pleasure entirely. Glad to discuss it.
And to you, our listener, we really trust this discussion has provided some valuable insights that might enhance your clinical practice when you encounter these, albeit rarely. If you found this deep dive valuable, please do take just a moment to rate and share our show. It really helps others find it. Join us next time on Deep Dive Ortho for another exploration into the cutting edge of orthopedic knowledge.